Right, I think we're ready to go.
Hey, welcome everyone, and thank you for coming tonight at such short notice. My name's Michelle Daly. I'm one of the public health nurses at Townsville Public Health Unit. Firstly, I'd like to do a welcome and acknowledgement to traditional owners. We would like to acknowledge the traditional owners of the land we are meeting on today, the Walgarukaba and Bindal people, and pay our respects to elders both past and present. Now just a bit of housekeeping. The toilets out this door and to the left of the foyer, across the corridor is where the toilets are. For fire evacuation, you go out either of the doors on the left or right here and through the main doors and across into the quadrangle directly in front of Robert Douglas Auditorium. And
phones?
yes, we'd like everyone to turn their phones off, please. As far as GPs, this self-reporting will be how you'll have to do this tonight because we didn't have enough time to organise for CPD points. And now I'd just like to introduce Dr. Stephen Donoghue, a public health physician for Townsville, Mackay and Mount Isa, and also Dr. Rob Norton, who's here this evening, the clinical microbiologist and director of pathology at TTH, and also Dr. Natasha Frost, who's obstetrician and fetal medicine consultant. Could everyone at the video conference sites please mute now? Thank you.
Thanks, Michelle. We've got a lot of stuff to go through, so if you wouldn't mind, maybe we can hold some of the questions until the end, although I do want Rob and Natalie to chip in if there's something that I've missed. I called this talk Waiting for Zika after a famous play called Waiting for Godot, which is about someone who's not actually present and, in fact, never shows up. And we would certainly like that to be the case with Zika, but we are not waiting, because if we had an outbreak, this would be a disaster, and therefore we're working very hard to make sure that it doesn't happen. Okay, so we'll just talk briefly about what Zika is. Does it cause birth defects? That's the big question. Will it come to North Queensland? Can we stop it? Some of the advice about travel, sex, pregnancy, what we need to do about case finding and surveillance, and what we need to do in terms of prevention at all stages of a possible outbreak. So, Zika is not a new virus. We've known about this for many years, and it's always been rather obscure. One of dozens of viruses that didn't appear to do very much and were in other countries and didn't really bother us. And that map shows how it was first discovered in a monkey in the Zika forest in Uganda in 1947, and certainly the African strain has spread to West Africa and caused some outbreaks there, but small numbers of cases. And then I came across to Asia. Around 2010 were the start of some rather big outbreaks. So somebody's got their mic on remotely. If you could just turn that off. There was a well-described outbreak on the American-run island of Yap, where 75% of the population were affected. We need all the microphones off at remote sites. And that's where we got the information that 80% of cases are asymptomatic. So a very well-described outbreak, but certainly such small numbers that you would never know whether there were birth defects. And so not just Yap, but a whole lot of Pacific islands, including the Cook Islands, the Vanuatu, etc. Of course, then it's gone to French Polynesia, where the first reports of birth defects came. Following that, it's gone ballistic in Latin America, mainly northeastern Brazil, but some other countries, Mexico now, and concerns that it will get into the US. I'm just going to go. Okay, so. Oh. Sorry, I've just gone too far forward. All right, here we go. Got it. Right, so what do we say about Zika clinically? This is although it's called an arbovirus just means a mosquito-borne virus. In fact, it belongs to the family of viruses called flaviviruses. It's a single-stranded RNA virus. There are many of them. Even here in Australia, we've got some obscure flaviviruses called Alfie, Stratford, Cockabeara, what was the other one? Edgehill. All things that don't really make people very sick. This is a short illness. Just like dengue, you're usually over it within a week. 80% of cases have few or no symptoms, but you might get a fever, you might get sore joints. They say it's more often the hands and feet than the large joints. Headaches, classically behind the eyes. You might get swelling of the joints, you might get muscle pains. They describe a conjunctivitis and also a rash. Now, all sorts of rashes can happen with flavivirus infections. This one is supposed to be more often maculopapular and on the trunk or the upper trunk. And then after the illness, people are tired and feel weak, but of course they become immune and should not get the disease again. And that's probably why some of the small Pacific Island outbreaks die out, because enough people have become immune. Differential diagnosis. Now, Rob Norton could reel off about 20 diseases. I'll have a go, Rob, and you can see if you can add. Rubella, measles, parvovirus, malaria, leptospirosis, adenovirus. Keep going, Rob. So it's very difficult clinically. There are old-time general practitioners who tell you that they can tell the different arboviruses apart clinically. Of course, they're lying. And of course, we have no vaccine or treatment at the moment. Oh, I don't know what's going on with the slides. All right, this is a kind of family tree, or the phylogenetic tree of the flaviviruses. Starting at the bottom there, dengue 3, dengue 2, dengue 1, St. Louis encephalitis, dengue 4. And then at the top, you can see Zika Uganda, the African strain, and Zika that was discovered in Asia. So slightly different strains in Asia, Africa, and the African one stayed put and the Asian one has gone to Latin America. Now, they're all very similar. At the top, Murray Valley, Alfie, West Nile, or Kunjun as it's known in Australia. On the far left there is a tick-borne encephalitis, and then down further, yellow fever, Japanese encephalitis. You can see a lot of these viruses cause encephalitis. Even dengue can do that. So it's not unusual for these viruses to attack the nervous system, but they could have just as well called this virus dengue 5. The reason why there are 4 dengues, by the way, is you have to get immunity to each one and you can get the others. Think about it. Dengue 5, only silent. All right. And the other big issue here is that it's really here in North Queensland only one type of mosquito that spreads the disease. Aedes aegypti. We're talking about the elderly females. Only females drink blood. Only the elderly live long enough to get infective with this virus or dengue. These things are highly adapted to human habitation and they virtually only bite humans. They live only around buildings and human habitations, and they breed only in freshwater artificial containers, not swamps, bush, lakes, rivers, large puddles or drains. So these things are human specialists. They're exotic, they don't belong in Australia. I wish we could get rid of them, but we can't. They sneak into the house, they hide in dark places. You will not know if you've been bitten by this mosquito. They're very quiet and shy. If the patient tells you they've been bitten by mosquitoes, it's irrelevant. They will not know whether they've been bitten. The extrinsic incubation period means how long does it take for the mosquito to develop the disease and become infective for life? And it's probably around 10 days. So these are not bush mosquitoes. There's only one type of mosquito that we need to combat, and that's Aedes aegypti. Except, of course, in the Torres, there's one more that we'll come to. Yeah, I really can't get this thing to move slides. Here we go. All right, let's talk about this idea that there are birth defects. There's been a lot of speculation in the press about this. Remember first that microcephaly is not a syndrome, it's a measurement. It's the limits of head circumference, and arbitrarily we say at about 32, that's where you're beyond normal and you're starting to get very small. Now, some people with small heads have normal intelligence. Others with small heads, particularly very small heads, have got massive brain damage and are profoundly retarded or may not survive. The reports are mainly coming from northeast Brazil, and the question's been asked, well, what about all of these other countries that have got massive Zika outbreaks? Why are we not seeing the same reports there? Well, one answer is some of the reports are beginning, but also some of these countries have got very poor information systems, great difficulty making the diagnosis, births that are not registered, and all sorts of biases and hysteria around what information is being put forward. So we have to be very careful evaluating these reports. Certainly it seems to be predominantly in poorer people. We don't know what that means. Is it nutrition? There are all sorts of things being fingered. Vaccines, insecticides, larvicides, all kinds of possible environmental factors. But it's really hard to see such a concentration in space and time as we see with microcephaly and the recent onset of large Zika outbreaks. There was one study that is looking at a great big birth cohort where they took data for cardiology purposes, and what they've suggested is that there was actually quite a lot of microcephaly even before Zika was supposed to have arrived. It was generally at the milder end of the spectrum, and even so, there's been a steep increase in severe microcephaly since late last year. So we're not out of the woods. Got it. Now, the case of the prosecution. Even before the outbreak in Brazil, we were talking about reports from French Polynesia that there were birth defects and neurological problems in children, even a suggestion of Guillain-Barré syndrome. As I said, in most of the other places, including Pacific Island, the data numbers, the recording systems were too small or too weak to pick up an increase in what is actually a rare condition. We now see some quite specific issues going on. There's calcification of the brain, quite a specific pattern of eye and neurological system damage. Natalie may want to talk about this, but also some of the cases have been well described as having fetal infections with Zika virus. We know that it can cross the placenta and infect the fetus, and there are several now published reports of kids with severe brain damage and microcephaly who were definitely infected with Zika. So, look, what I heard late last week is that World Health is probably imminently going to say that this is a real effect. I can't, there's somebody making a sound on the remote microphones. If you could mute for now, please. We'll have questions later. And they made a declaration of a public health emergency of international concern about the birth defects, not necessarily Zika, because we're still working out the link. Guillain-Barré is a rare autoimmune demyelinating neurological disease which may have increased as well. So we think it's real. What would the risk be? These are some numbers that my registrar did on the back of an envelope. They're very rough. If you say that microcephaly happens about 5 per 100,000 births, and in Brazil they had 4,700 cases maximum, that's all the reported ones. They're only confirming about a quarter of those, so it would probably be much less. In 2.9 million births in Brazil last year. That would be a rate of up to 162 per 100,000, which is up to 32 times the background rate. So this is a big increase. Right? It might only be 5 or 10 times the background rate, but it's very noticeable. Now, if last year they had about 1.5 million infections among the population, and we applied that same attack rate to all the pregnant women, we would say that there'd be about 21,000 affected pregnancies. That is, women who got Zika virus at any stage of pregnancy. Now, therefore, if you crunch those numbers, the risk of somebody pregnant with Zika might be anywhere between 3 and 15%. So the majority of these babies are not damaged, unlike what the media are saying. But certainly that is far higher than you would expect from the background rate of microcephaly. So lots of uncertainties here. All of these silent infections, are they just as damaging as an overt infection? We don't know. Chances are that the damage to the baby is independent of the symptoms in the mother. What stage of pregnancy? We know that newborns can get Zika and they're unharmed, so it's likely to be one of these first trimester or early pregnancy things. Again, we don't know for sure. We do know that breastfeeding is okay. It's never been reported to be transmitted by breastfeeding, and even if it was, that baby would not be harmed by a mild infection. So the benefits of breastfeeding far outweigh any theoretical risk. All right, I want to go through some of the myths in the media. I've actually had to collect them this time to get my brain straight. The typical thing in the media is to say Zika is carried by Aedes aegypti, and Aedes aegypti is in North Queensland. Naturally, people assume that the virus is here, but of course these mosquitoes are not born with the virus in them. They have to catch it from somebody who brought it in from overseas. The vector means that we've got a receptive area. I'm going to show you later that there are lots of areas with low numbers of vectors who will never get dengue and who will never get Zika. PHEIC spells Global Zika Emergency. Incorrect. There's a significant amount of infection coming from sex or blood transfusion or even monkey bites. Nonsense. We know that other arboviruses can be occasionally, on rare occasions, transmitted sexually. There have only been 1 or 2 reports. It's unlikely to be significant. Others have been saying that it's central Queensland, southern Queensland, Queensland, or far north Queensland that's at risk. It's in fact North Queensland, at least from Charters Towers north, where we've had dengue outbreaks. Others are saying that the Eliminate Dengue program, that is the bacteria that are carried by these mosquitoes that resist virus replication, are GM. Well, they're not GM. They're basically carrying a natural commensal organism. Every TV show will show large amounts of fogging going on, big machines, firing out huge clouds of smoke, and every time we have a dengue outbreak, people demand the same treatment as they've seen on TV. We don't do it here because it's ineffective. It only kills a few of the mosquitoes. The ones hiding indoors are unaffected. It's just a waste of insecticide. And of course, all the babies get microcephaly when we're showing that it might be 5%. So this is something you will not see in North Queensland, I promise you. So a lot of unknowns here still. Is it a real link? We think so, but maybe next week I'll tell you something different. There could be a lot of other factors involved. Nutrition, other environmental poisons, other antibodies. We know, for example, that severe dengue cases often depend on enhancement of previous antibody, where you've had a previous dengue infection of another type, and that antibody makes you get a severe infection. Whether that applies to Zika, we don't know. Is an asymptomatic person transmitting the virus effectively to local mosquitoes? Again, we don't know. But given that there have been very large outbreaks, you have to assume that it does. How often is it sexually transmitted? There have been, I think, 2 reports of Zika virus detected in semen, and one of them was 2 months after that person's illness. So it's theoretically possible, but whether this is important, we don't know. We only have 1 recorded case of sexual transmission. And is Zika circulating in places like Bali, which are not on the list of outbreak countries right now? On a small island, Zika or dengue 2 or whatever will burn out and go away. In big places, you can have low-level transmission continuing for a very long period. So we don't really know where the risk countries are. And many of these poor countries don't have the ability to do the testing required. Another serious theoretical problem is that we don't know what mosquitoes would carry it in Australia. In the Pacific, there are related Aedes mosquitoes which can transmit Zika, and Vigilax and Notoscriptus are some of the commonest bush mosquitoes in Australia, which would be nasty. Now, I don't think that's actually happening because otherwise the virus would be spreading here already. But it's certainly something that should be checked. So, will this disease take off in North Queensland? We've got the major vector, the one that affects people the most. It's an efficient vector because it bites people only. It's the dengue mosquito. It also carries things like yellow fever and chikungunya. There is this Aedes albopictus in the Torres I'll mention. We're in the middle of the wet season. We've got a completely non-immune population here. We've got direct flights from Cairns and Townsville in and out of Bali every day. And we've got a Brazilian community in Cairns. So lots of opportunities for the virus to come in. We've recorded imports. About half of the 10 or so Zika imports we've known about in the last couple of years have been into North Queensland. And we haven't had an outbreak yet, even when it was raging in the Cook Islands and Vanuatu. What do we mean by the receptive area? What is the area that is at risk of getting an outbreak? Well, that's the map of Queensland. Red is where we've had outbreaks of dengue in the last 20 years, and blue are some of the other towns. But if you overlay on that the known range or distribution of where you can find Aedes aegypti, it's much bigger. Remember, of course, that it's only the urban areas. The bush areas in between don't have Aedes aegypti. But any of those towns, you might be able to find Aedes aegypti, but in such small numbers that apart from an abortive one round of transmission, it's never going to sustain an outbreak. And the other reason, of course, is that you need humidity and high temperatures for these mosquitoes long enough to become infective and then to transmit to other people. Young females don't cut it. Yeah, they're too... So shorter-lived mosquitoes further south. Having said all of that, we do know that Brisbane and New South Wales have had dengue in the past when people were hoarding water at home because we didn't have piped water in the past. But the key to where we would expect Zika is exactly those red areas where we've been seeing dengue, not the rest of them. So the receptive area and the range of where the mosquito are found are not the same thing. If you look at the number of dengue outbreaks in North Queensland over the last 20-odd years, there's been a big peak recently. Better detection, more travellers, more imports. But also, refreshingly, there's been a bit of a dip in the last couple of years. And I need to explain why things are looking better at the moment. We've been saying that a Zika outbreak here is unlikely. We think that North Queensland is pretty marginal. If you compare the environment in the favelas of Brazil, for example, these are slums full of rubbish. You take a piece of stuff like this empty water bottle thrown away. That's not one breeding site, it's two. You need that much water to grow Aedes aegypti. So they've got massive numbers of vectors all over the place, whereas we've got a relatively clean environment, good housing, screened air-conditioned places, lawn mowers. It's a very different environment. We know that health promotion works. We haven't had a dengue outbreak in Mackay for at least 50 years. Partly due to really good health promotion there. It's very hard to find Aedes aegypti in Mackay at the moment or further south. And of course we did survive the big Zika outbreaks in our Pacific neighbours. Lots of imports that are known and unknown, and we didn't get an outbreak. But one of the biggest factors now is that the Eliminate Dengue program, which is releasing modified Aedes aegypti into Townsville and Cairns suburbs, have a bacteria in them that blocks dengue and Zika. That's the progress they've made so far in Townsville. The grey area is the high-risk suburbs, which are already covered with 78 to 80% penetrance. That is, 78 to 80% of all the Aegypti that you catch will be Wolbachia mosquitoes resistant to dengue. If we get an outbreak, move to those suburbs if you're pregnant. The other suburbs, they're commencing this year, and it's really important for us as health to support that program, because I think it's now one of our top defences against dengue and Zika. There is a lot of talk further south about the threat of exotic mosquitoes. For example, the Asian tiger, Aedes albopictus, it lives in temperate climates. It could go all the way to Melbourne. It's a reasonably good vector of dengue and Zika. So far we've been able to keep it out with harbourage sprays in the Torres Strait. It may come eventually, but it's not going to drive a big outbreak on mainland Australia. It could contribute in the Torres. But the idea that we've suddenly got to ramp up exotic mosquito detection in Brisbane has got nothing to do with Zika. Probably of more concern is what's going on in the Torres Strait and PNG. We don't know if PNG has got a lot of Zika at the moment, or any. We don't even know whether it's already got into the Torres Strait. As I say, most people are not sick and not getting tested. There was a report in a paper that said somebody had been bitten by mosquitoes and a monkey in Bali and then got sick with Zika. Therefore, they got it from the monkey. Now, I don't agree with that. I think that's a problem with the logic. But it's not port incursions, it's really, whether or not the traffic between these countries could lead to an outbreak in the Torres, and then people would move further south. So outbreaks are random phenomena. They're like spot fires across the suburbs with Aedes aegypti because they don't move very far in their lifetime. The big movements come from infected people, but the mosquitoes don't move very far. And then they can seed an outbreak in another place and that moves out. Now, the whole thing about dengue control is that we know where it is because people are very sick, at least the adults. And most of them will go to the doctor and some of them will get tested. So, to do dengue control, we've been very good at tracking the mosquitoes and the cases across the suburbs and responding very aggressively to where those mosquitoes are. Hang on. In fact, Australia is one of the few countries on earth that can stamp out dengue outbreaks. They use high-tech, expensive, labour-intensive methods to decimate the Aedes aegypti population, not other mosquitoes, just that one species in the whole neighbourhood to stop it spreading to other mosquitoes and other people. So what's the big problem with Zika? If 80% of cases are asymptomatic, and they're probably infectious to dengue mosquitoes, although we don't have confirmation, they would probably have a lower viremia, maybe less able to infect mosquitoes. But, if the virus is there, it could get into a mosquito. We've certainly seen explosive outbreaks in other countries, so I think it is something that transmits efficiently. If it's not detected, then we might find out in 9 months that we had Zika in North Queensland, which would be a disaster. So it's impossible to track the disease accurately. It could be widespread and intense transmission before we know what we're doing. Similar to a large outbreak of dengue we had in Cairns 2009, where it actually got beyond us. We had to do citywide control because the focal control was no longer working. It had already gone too far. That could lead to a panic for pregnant women, particularly if the media get hold of it. And that could lead to a lot of demand for testing and obstetrics and whatever else that we wouldn't be able to meet. So I'm not saying it's coming here, but I'm saying if it did, it would be a big problem. So, as I say, the response map that we use for a dengue case, within 100 metres, we will spray the houses, put in traps, kill virtually all of the Aedes aegypti, and for another 100 metre radius, We'll do source reaction, reduce their breeding. To the extent we nearly always interrupt transmission. But we have to know where the cases are, and that's our big concern at the moment. So that's what we would put up in a dengue zone. Some of those methods will work, but not necessarily the local control element. So it's a high-stakes strategy. We may not be able to stop it, therefore it's really important right now to prevent an outbreak. And we need early detection. That's where doctors come in. If only 20% of people get sick, then we need to not miss it in those who do get sick. So a lot of work about testing, that's why we've got a handout, I'll talk about it, and a surveillance program where we might add testing to other likely suspects. We need to do more health promotion, better than we've done it before about dengue, and perhaps doing vector control, particularly focusing on young mums. So our teams in the off-season, before we get dengue, always go and do tourist hotspots, caravan parks, backpacker hostels. Now we're thinking about where young mothers might be, primary schools, daycare centres, spraying them to make sure that they're clean, they don't have Aedes aegypti around those buildings. Because we might need to do a citywide response and we simply don't have enough trained insecticide or pest control technicians to do all of that work. So, what else can we do? Encourage people to participate, release, eliminate dengue mosquitoes. As I say, if you really want to prevent this happening in your household, ring up Eliminate Dengue and get some of those mosquitoes released around your house. We're standing up our teams. We're in outbreak mode. We're ordering extra supplies. We've got permits, particularly for some of the smaller towns that don't have Eliminate Dengue. Charters Towers, Innisfail, Ingham, Tully, those sorts of places. And we're trying to improve our communications without leading to a panic, because we think that probably the number of infections will be small and birth defects due to this will be uncommon, but we can't be sure. A lot of it is about vector control at home by what people can do themselves, and then recognising potential cases. We would like to know in advance, before you have a test result. These things are notifiable on suspicion. So if you've got a strong case, somebody who's got the typical picture and has been to a Zika endemic country, then I want you to ring us up so we can respond even before we have those results. And we'll talk about how to test. So simply waiting is not going to work. We can't just say, oh, well, we'll respond when we get some cases. Dengue control is really good in North Queensland. Well, I've just told you why we have a weakness and why it might not work. So we're doing everything we can to improve prevention. So this is a specific vector. It's not a bush or swamp mosquito. One of our biggest problems is that people will do everything that they can to remove containers around their yard and will not notice any difference in the number of mosquito bites, because all of those nuisance mosquitoes of other species from the swamps or the town common are still coming. All right, don't expect to notice a reduction in mosquito bites. These things are very quiet. You will not see that. But remove containers, remove anything that can hold water around a building. We sometimes use methadone, which is an insect growth regulator. It's like a hormone which stops mosquitoes from developing. Using zappers and coils and spray at home. Wearing long sleeve clothing. Aedes aegypti bite you on the legs and the feet. So it doesn't matter if you've got insect repellent up here. If your feet are exposed, that's where you're likely to be bitten. We know that diethyl toluamide, that's ordinary Erigard, for example, is safe in pregnancy. But unfortunately, most people don't use insect repellent often enough. They don't reapply it. It's a bit like the problem with sunscreen. But DEET is safe in pregnancy. And then I'll show you some of the specific traps that we use. These things, female mosquitoes need to lay their eggs, and they're looking for water. And so we make water traps that can kill them very efficiently. But the other thing that we do is a thing called interior residual spray. Again, a very safe insecticide. It's a pyrethroid called bifenthrin, whereby they will spray in dark hiding places in and around your house. We know that if the insect rests on one of those surfaces, it will either die immediately or will not live long enough to be able to continue the cycle. So, in the big outbreak we had in 2009 in Cairns, the estimates are that if you had interior residual spraying of your house, you reduced your chance of getting dengue by 90%. It would be the same with Zika. Now, if we had a drug or a vaccine that offered 90% protection from Zika, they'd be demonstrating in the streets to get it. All right, so interior residual spraying is something that we could do for pregnant women if we had an outbreak here in North Queensland. In fact, you can almost do it yourself. We don't have enough technicians, but if you go to an ordinary supermarket and buy ordinary surface spray, this one costs $2. It's got permethrin and tetramethrin in it. Take a can of this. The pregnant woman doesn't have to be in the house. And just spray your porch. I do this at home. I spray the porch, I spray under the furniture outside, I spray around the doors, and in the lower story of the house, because it's a Queenslander, everywhere where these things might hide. We don't have a lot of mosquitoes at home, and it's very hard to find gyps. All right, so up to 90% protection for household members, and it will last 2 or 3 months. So if we had a big outbreak situation, we wouldn't have enough technicians. We would have to tell people how to do this. And an insecticide, as I say, a safe insecticide is much less risk than getting a malformed baby. Now, there's a lot of stuff that we need to do about health promotion. Now, if we had, let's say, a cholera outbreak, then a message like avoid germs is not really specific enough, is it? Similarly, avoid mosquito bites isn't quite specific enough around Zika and dengue. We need to build on the dengue awareness, explain to people this is a different mosquito that lives at your home, not in the bush. If we say there's an outbreak going on, there's going to be a lot of demand for testing, a lot of people going to the doctor, all of the pregnant women will want testing, and we want to avoid that situation. So all of the stuff about travel advice, high-risk settings, and regulation. All right, the pictures I've got there. The little Lego thing on the left is a road speed barrier. They're all over the place where they're building roads. They fill them with water so you can't move them. Perfect breeding sites. I'm going to be asking local government to ban them in North Queensland. The middle picture is a road sign for the Defend Against Dengue campaign, implying that you see this mosquito when you go out in your car. No. We would be better off having the slogan or the logo on the right, which is a dengue mosquito inside your house. That's where they live. So we need to change the information campaign. Where does it breed? Places like this, old tyres, old containers, buckets, boats, pot plant containers, and it's really the older suburbs, overgrown gardens, poor maintenance, that we have a problem. These brand new housing developments are very clean. It's very hard to find a gyp dye there. There are people who like to collect stuff in their backyard. We call them junk rats, and they never throw anything out. So that old washing machine will fill up with water. Also, with regard to travel advice, particularly for pregnant women, or even contemplating pregnancy in, let's say, 1 month before, because we're not quite sure of the time periods or the incubation periods. Don't go to any of these listed countries, is what the Australian government is saying. That presumes we know where the Zika is. What I would say to pregnant women in North Queensland is don't go to any country that is endemic for dengue, because if it can have dengue, it can have Zika. Because of the reports of sexual transmission, the same advice would go to sexual partners. And if we think a sexual partner has been infected, then they would have to abstain or have safe sex for the duration of the pregnancy. Why? Because we know that it can last in semen for a long time. Mosquito avoidance advice. I don't know whether the lady in the picture has got malaria tablets or whether she's got insecticide or repellent. I'm not sure, or maybe oral contraceptives. But, yeah, travellers need to be aware. You can put permethrin, another safe pyrethroid insecticide, on your clothing. That works very effectively. And bed nets, although, remember, a Aedes aegypti bite during the day, a little bit in the evenings. So I wonder if people could just grab the handout. I don't want to make this too complicated, but the testing guideline is this. There are 3 things you have to worry about: the travel, the clinical picture, and pregnancy. And the next 2 columns are very simple. What we should be doing in the non-receptive areas, that would include Mackay and some of the smaller towns out west which do not get dengue outbreaks. They don't have enough gyps and they don't live long enough. All right, but anywhere, in any of the towns, from Charters Towers and Townsville north, we would call those receptive areas. So obviously we're looking harder in the receptive areas, right? It's a surveillance objective. And so really, you can see that the result of looking at whether those indications are present is if you've travelled and you've got one of the other indications, you should test if you're in the non-receptive area. But in the receptive area, like here in Townsville, it would be any 2 of those criteria. That's the rough guide. I don't want to spend a lot of time on this. The standard testing would be the PCR test and serology. PCR detects the virus and it's very accurate. Serology is difficult, as I'm going to come to. Sometimes we would have to do a second blood after a couple of weeks if the serology is unclear. And you must notify on suspicion so that we can do our bit. All right, let's just go into a little bit more about this. This is actually adapted from a diagram of what happens in dengue, but it's very similar in Zika virus infection. There's the mosquito bite. 4 or 5 days later, you start to get sick. You probably have the virus in your blood the day before you have any symptoms, if you have symptoms. And then so for the whole duration that the virus is present, you can detect it by doing PCR. It's really important to test people early in the illness if you want an accurate answer. After that, you might be guessing. All right, it takes 4 or 5 days, perhaps up to a week, for antibody. That's your own immune response to the virus to appear. And those graphs show that IgM appears pretty quickly, and then after that, IgG rises and stays up for a long time. Probably immune to Zika for life. So what I was going to say is dengue PCR will be negative in Zika cases, and dengue NS1 protein, which is specific to dengue virus, will be negative. These people do not have disturbances of their full blood or their liver function tests like in some of these other viruses. But if you missed it during the illness, then you've got trouble. Then you're relying on what I call the black art of serology. Why is it difficult? All right, remember, it takes several days for antibody to appear in the first place. And then it can cross-react, or it can be a false positive. So, as I mentioned, there are dozens of other flaviviruses out there, or you might have been vaccinated against Japanese encephalitis or yellow fever in the past. Or it could even cross-react with totally unrelated viruses like Barmah Forest Ross River. So it's difficult. Don't delay the testing. There's a thing called original antigenic sin. Let's say that my first flavivirus infection in my life was dengue 3. Well, the next time I get any one of these other flaviviruses, guess what antibody is going to pop up? Dengue 3. All right, it can be very confusing. So we often need a second serum. We often have to test them in parallel, to put both bloods back in the same machine. We have to do confirmatory neutralisation tests. Although the evidence from serology is persistent, it's very difficult. And there are formalities like validation that laboratory people worry about that I won't go into. Rob, have I presented the case accurately? Don't wait, all right? Test early while they're sick if you want an answer. Otherwise, you will just get a prognostication. Also, reduce the time lost in all of these stages. If we're going to really combat and get rid of and keep out Zika virus, then we've got to look at delays. How long do they take before they go to the doctor? Does the doctor delay? Does the lab delay? What happens in the public health unit when you ring us? And how quickly can we do the vector control response? Now, changing the subject slightly, that is a picture of a canary in a coal mine. What used to happen in the old days is if the canary dropped dead, they said, hell, that's carbon monoxide, we better get out of here. Now, did they do this for the benefit of the canary? No, they didn't. They did it for the benefit of everybody else. So the difference between case finding and surveillance is case finding is to help that person. That's what GPs normally do. But surveillance is incredibly important because we have to know as a community if and where Zika is spreading. So that's why it's notifiable and that's why you must be quick. We have to know where it is. So, surveillance for imports, surveillance for local transmission. We can do surveillance on the vector itself, how many there are, what percentage have got Wolbachia if you're lucky enough to have that protection. We can do virus surveillance, looking in the mosquitoes to see whether they're infected, but in fact the pickup rates are too low and too expensive. We can do vector competence studies, as we've said. We can do disease surveillance, that is looking hard, looking additional effort to find cases. And so we're discussing now with Rob in the laboratory here, which will have the PCR centre for Queensland moved to Townsville Hospital. What other bloods could we look for? And the initial thinking is Ross River or dengue suspects. The blood was sent for those diseases, but it was negative for those diseases. Maybe we could add a Zika to some of those, depending on capacity, to see if we could pick up Zika virus earlier. We need those complications. Again, not a good surveillance method. Remember, microcephaly is a rare disease. It's going to be hard to pick up a difference. Same goes for Guillain-Barré. So it's a clinical notification. It goes into a database. We map them. We get out there and get rid of them. So we're talking about perhaps an add-on testing program for surveillance purposes to help other people. All right, and then we've got to act on the results. Pregnant cases, all we can really do is refer them to the obstetricians for counselling, confirmatory testing, sometimes serial ultrasound to see whether there's anything going wrong with the nervous system development and brain size. Very depressing stuff. And again, we have only got a small number of people in obstetrics. We don't want to go there. Partners of pregnant women, again, safe sex because of the possibility of sexual transmission. We don't know how important that is. Imported cases, it's really important that those people be quarantined from local mosquitoes. All right, so they would get repellent, zappers, coils, screens, aircon, anything to keep them away from local mosquitoes. In fact, we would do the interior residual spray in the house. And then do the full-on vector control in the neighbourhood, hoping to catch it. But of course there are all these undetected cases that are going to be out there. If we had even one locally acquired case, then all bets are off. We could have a massive outbreak and that could just be the start of it. So it wouldn't do just to do the neighbourhood vector control. We would have to do citywide vector control and everybody would have to get involved. All right, we need to avoid that. What are we going to tell the pregnant women? All go and get tested? All go and get tested every week? Are we going to tell them to leave town? Are we going to tell them to spray their own houses? Think about it. Very difficult. So, know the enemy. A little thing about health promotion. People think that active health promotion is the best. That means people have to think and respond and get involved. We know the most effective health promotion is where people don't have to think, where we change the environment to make diseases harder to control. So we need to do everything possible to make our environment hostile to Aedes aegypti. so that there's not enough of them to sustain a big outbreak. Go after the specific vector, not mosquitoes in general. That's a waste of time. Detect cases quickly, rapid outbreak response, and try and break the transmission. Right, and with multiple barriers, we might get away with it. So this is just an example of how we kill Aedes aegypti in a neighbourhood. You can see the pest management technician who does the interior residual spray in the house, 90% protection. You can do it yourself, and it's certainly what I do at home. Now that thing at the bottom there is bed net, the new high-tech bed nets that actually have permethrin impregnated into the plastic of the netting, and it lasts for years even if you wash it. We actually use that material in some of our nets. These are ovi-traps. There's a tiny amount of insecticide either in the netting or in that red strip. The female that wants to lay eggs will go in there, will land on the strip, and will not live long enough to transmit to another person. By the way, we make sure those eggs don't hatch as well. So Zika is a game changer. A milder disease, unfortunately, is harder to control. So we need to detect cases early. An outbreak here would be a disaster. So we're not waiting for cases. We're ramping up prevention. We're in outbreak mode already in terms of preventive work. So business as usual is not on. And a lot of it is not just about radio and TV. It's about enforcement, local government, health department, all sorts of partners in the community as well as our researchers. And certainly we need to think carefully about how to protect pregnant women. So in summary, there's good news and bad news. The disease is probably not here. It probably does cause birth defects. Outbreak control will be more difficult, and so we need stronger prevention, including this whole thing about people spraying their own houses and getting rid of breeding sites. We need to get the communications and the travel advice right. We need to do more in terms of vector control, including the Eliminate Dengue program. And I've given you a little bit of guidance on testing. You can sort of take that home and look at it. And also some of the material that we're giving out, that little brochure is, in fact, what we put in people's letterboxes when the Eliminate Dengue team go around. It's basically saying, look, all of those things that you did for dengue, they will work for Zika. All right, and then additional surveillance, for example, in the laboratory. And, yeah, an outbreak would be very nasty. So that's all I want to say now. If there are some questions, now's your chance. Perhaps we could start in this room first. And Rob Norton and Tracy can help me if there's something out of my... Natasha, sorry. Any questions? Yes. Okay, so the question is who's doing the pathology? The other labs would have to send it to Queensland Health. At the moment, it's all done in the reference lab in Brisbane, but the PCR element will come here to Townsville. Thank you. Anything else? Yep. Okay, so the question I think is from a GP at the back saying, should we just knee-jerk add Zika testing to anybody with suspected Ross River virus? I think you would need, that's a very large amount of testing if we were to do that. Certainly the answer would be no if you were living in a non-receptive area. But here in a receptive area, if you had a good clinical history, yes, add Zika. Because it might be spreading and we don't know it. Particularly if you're in an urban receptive area. I'm not talking about out in the bush or in Cloncurry. Yep, other question? Yep. What's the turnaround on the tests, Rob?
Once we get it going, we start the 1st of March, hopefully we'll get it back within 24 hours.
Okay, so Rob says that from the 1st of March we'll be doing PCR in Townsville and we should have a result within 24 hours at this hospital. Any other questions? Can we go to the online sites? Turn on your microphone and ask a question.
It's Charters Towers here. That slide mentioned urine for the PCR test. Was that urine or blood?
Thank you for asking. I forgot to mention that. There's good evidence now that Zika persists for longer in urine. This is particularly important for pregnant women where we might have missed the onset of the illness, or she's come back and she thought, well, maybe 3 weeks ago or 5 weeks ago I was exposed to Zika. So it persists longer in the urine. For pregnant women at least, we would be adding a urine PCR as well. Thank you for that. Any other questions online? Yes, one in the room. Yeah, Guillain-Barré syndrome is the question. Does it appear in babies or adults? It appears in adults and young adults as well. Yeah, it's not a baby problem as far as I know. Thank you. Here, another question.
Well, I've just, over the last probably 5 weeks, had 3 separate cases where it sounded very much, I guess, like Zika. Then got the blood and nothing came back.
Right, so the question is that last few weeks the doctor has seen some cases that could have been Zika. They look just like that clinical picture. She sent off the bloods and didn't get a result. Is that what you're saying? Private lab or public lab? Yeah. Oh, you didn't order Zika. Yeah, so it's not an add-on yet, and the testing facilities are being ramped up very rapidly. But from now on, yes, I think if you really think that you've got an arboviral syndrome here in North Queensland, even as someone who hasn't travelled, then it's reasonable to add Zika. But if you're not in North Queensland, that is the receptive area from Charters Towers up, then if they haven't got a travel history, where did they get it? And does it matter anyway if they're not pregnant? Don't test.
We can go back and get the blood.
Oh yeah, and of course you could always retrieve the blood within the lab, yep.
Or would we retest them?
So would you prefer to test the old blood or retest them? The short answer is if you had blood that was taken during the illness, it's much more reliable to do that one. Thank you. Yep. Good question. So the question is about if you have multiple cases of dengue or different serotypes, that supposedly increases your risk of hemorrhagic fever. Would that happen with Zika? We don't think so. But I'm just giving that as an example of maybe that's one of the factors in severe disease is pre-existing antibody to other flavies. We just don't know at this stage. Thank you for that question. Anything else?
Stephen, it's Kevin Ziske here again. If you order serology and you have a viral test to it, the private labs keep that serum for 12 months. Yep. Secondly, if we are going to order the Zika test, should we send our bloods privately and will they send the blood across to Townsville, or do we need to send our patients to the local hospital?
Kevin's in Charters Towers. It would be fine to send it to the private lab. They will send serum to serology part to Brisbane and the PCR part to Townsville. And yeah, there should be very little delay. And I agree that often previous sera are stored, but remember the serology is not the ideal way to diagnose Zika. If you really want a clear answer, it's acute blood on somebody who's sick. Thank you for that. Another question in the room?
Is there any evidence that the information needs to be vaccinated with Japanese encapsulated for yellow fever and some protection?
All right, so the question is about is there protection from Zika in people who've been vaccinated for Japanese encephalitis or yellow fever? The short answer is there is no protection. There may be very short-term protection for related flaviviruses, but it usually narrows down very rapidly. That's my understanding, Robert. Yeah. Anybody else? Another question in the front.
Is there pretty solid evidence that IRS doesn't cause any problems with pregnancy?
Yeah, so the question is IRS, interior residual spraying. This is what I was saying, is something you could do for a pregnant woman. Is there evidence that that's safe in pregnancy? There's very good data on pyrethroid insecticides that they have negligible effect on mammals, including teratogenic effects. So I wouldn't necessarily have my wife in the house while I sprayed it. She can go shopping, but it's a very good defence. Thank you for that. Out the back. Good question. Okay, so the question is from the back. Unfortunately, people in the remote sites may not have the draft testing one-pager in front of them. I can email it. But on there it says that in North Queensland, you might want to test some of the people who have symptoms but no travel and are not pregnant. And he's saying, well, which ones? And I would say the answer would be if they really had a good, typical clinical picture and you're thinking of Zika, we don't mind testing those. We'd be happy to do so. But people who are not pregnant and haven't travelled and have got a flu-like symptoms in Brisbane, you're wasting your time to test for Zika because there's no utility. You can't treat them and it doesn't have a surveillance objective because you will not get an outbreak there. So only in North Queensland would be encouraging Zika testing for people purely on the basis of symptoms. Does that answer the question? Thank you. In the front again. Okay, the question is, have we done serological screening or serosurveys of people who have returned from Brazil? It's certainly not been done in Australia. I'm sure that somebody's doing it in the United States because there's much more traffic between Latin America and the US. And those kind of studies hopefully will be coming out in the next month or two. Good question. Yep. Okay. So the question is safety for infants of interior residual spraying. Again, these are pyrethroids. Pyrethrins is a product from flowers, chrysanthemums. There is very, very low mammalian toxicity, although you wouldn't spray it on the baby. And you're not trying to spray it on the floor. You're spraying it in dark hiding places under or behind furniture. Thank you. Yes, another question in the room? Okay. Yep. All right, so the question is, again, here in North Queensland, how can you advocate Zika testing in virtually anybody who has a flu-like illness? And I guess there has to be a bit of common sense added here. I'm not saying that everybody with a flu-like illness or any kind of rash must be tested for Zika in North Queensland. I'm saying here in North Queensland, even if they haven't travelled and they're not pregnant, we are happy to test some of them if you've really got a feeling this looks like a typical Zika virus presentation. Why? Because we need to find it, otherwise we might miss it. But yeah, certainly we expect a bigger volume of testing in North Queensland than in non-receptive areas. Okay, so the follow-up question is, are there symptoms that would lead you strongly towards Zika as opposed to other mild acute infections, Robert?
Yeah, I think the main point is that when 20% of cases are really symptomatic, so a short answer would be not really. People talk about conjunctivitis, fever, so on, but the reality is that those of your general practice will see somebody with this every day. So it's not going to be a great help in that sense. I agree completely with what Steve said. I think the first thing is the travel history, second thing is surveillance, and the third thing is the pregnant woman. You've got to somehow link those.
Right, so Rob Norton answers and he agreed with me. There is no particular symptoms. A typical syndrome in somebody who's not pregnant down south, it doesn't matter because they will not get an outbreak. Up here, we're happy to test some of those if you think that it could be Zika, even without a travel history up here. Anyone else?
Stephen, it's Kevin Ziske here again. If people want more information about that study by the paediatric cardiologist in Brazil, it was on last week's health report on the ABC.
Yep. Thanks, Kevin. That's true. Yeah, there was a. You could just go onto the ABC website and the radio program, the health report, had something on that. They're extending that study and doing more and more pregnant women's infants' head circumferences and trying to put it all together. There will be a deluge of new evidence coming out in the next weeks and months. Yep. Okay, the question is about how long till we get a vaccine. Some of the most successful flavivirus vaccines, the new Japanese encephalitis and yellow fever, are live vaccines. You could not use those in pregnant women. It would be too risky. There are dead vaccines that are available, for example, for Japanese encephalitis, and there are vaccine candidates apparently emerging willy-nilly, but realistically it's going to take at least a year to, one, develop them, and two, run the kind of trials that would prove them. So it's not a prospect in the immediate future. Zika is here to stay. That threat will be here in Australia and in all of the developing countries for a long time, and we really need to do a lot more about dengue control than we did before, if this is a real link with birth defects. Thank you. Right, folks, I think we've... Oh, okay.
Hi. What advice should we be giving to women who are planning a pregnancy?
What advice should we give to the women planning a pregnancy?
Yes.
Well, one of them is don't travel... Well, what the Commonwealth is currently saying is don't travel to any country where we know that Zika is circulating. But I would go further. Because of this problem with low-level unknown transmission, I would say don't go to any country that is endemic for Zika, even if you're attempting pregnancy. Sorry, endemic for dengue. Thank you for that. Yeah, so the dengue countries I would worry about, not just the ones that are listed. If they insist on going, then they've got to have luxury hotel-level mosquito control. Screens, air conditioning, bed net, repellents, clothing. Yep, the works. And of course, ideally to delay pregnancy if they must go.
And would they do the same thing if they weren't travelling, if they were just staying in Mount Isa?
Right, Mount Isa is not a receptive area. There is no danger of getting a Zika or dengue outbreak in Mount Isa. However, we are getting questions every day about people wondering whether they should travel to Townsville and Cairns. If we have an outbreak, there's likely to be a travel advisory within Australia not to go to those areas. But we do not have an outbreak and we do not believe the virus is here. At the moment, it's safe for pregnant women. Remember, the probabilities are very low. When we have dengue outbreaks here in Townsville, it's usually only a couple of dozen cases, and maybe double that if you count the unknown cases. It's not going to affect every pregnant woman, and the percentage of their babies that are affected is small. It's not like all the babies will be infected. So at this stage, there's no reason to panic, and there is an enormous amount we can do to protect pregnant women, including interior residual spray.
Thank you.
Go on. All right, so the question is about the Defence Forces. What are they doing about their deployments, including young women of reproductive age who may get pregnant? Yeah, so my defence colleagues tell me that there are actually very, very few personnel in the Pacific at the moment. I'm suggesting to them that they return personnel via Darwin, because we don't have a GIPDI in Darwin. And then if they're there for a few days and they haven't had the illness, then let's bring them back to Cairns or Townsville. But I'm certain all of that travel advice is being adopted. I don't know whether Tonga you wanted to add. He's in the Defence Force. Or was, yeah. Okay. All right, so we'll hear more about this in the near future. Thank you for that. More questions at the back? Okay, so the question is, what about female travellers to Brazil for the Olympics. Two things, it might all be over by then because there's a massive amount of vector control happening in Rio. I would certainly take precautions to avoid pregnancy while there and then take pretty ordinary mosquito precautions, and that to me would be enough at the moment until we know more. Another question at the back? Okay, so the question is, how long does Zika virus last in the blood? We think that it lasts in semen for 2 months or even more on the basis of one report, but we know that Zika is cleared in the blood within about a week by our antibodies. So that person must be protected against mosquito bites, that is Aedes aegypti bites, for a week until they're better. And then you can relax. Thank you for that. That was an important question. All right. Yes, and another question. Question is about, are there travel restrictions on who is coming in? The answer is, of course not. That would be bad for business. Also, border screening would be totally ineffective because people could be incubating the disease and entirely asymptomatic. Travel restrictions also would be very impractical. And in fact, there are better things that we could do to prevent an outbreak. So let's target the mosquito rather than targeting people where possible. But yeah, that's important because it will come up. Anything else? All right, folks, so there's finally a gap in the questions. Thank you very much for your attention and your concern. Natalie and Rob and I will be here at the front. I will make sure that I email around the little handouts that came today, and this presentation has been recorded if you want to play it again. Thanks very much, everyone.